So Anyreach wires are my default wires now, and I have done more than 300 cases, and more than 200 of them are CTO cases. I am doing mainly CTO and mainly trying to finish my old procedures with only Anyreach wires. So I'm able to finish my procedure at 92% with only Anyreach wire in a complex CTO cases. And as a workhorse wire, I use the Anyreach 0.6, and also sometimes 50% I use also 0.3 for regular cases and complex cases, as well as a workhorse wire, because it has the moderate support facility of the body of the wire, and helped me a lot to have a better support for advancing any devices through lesions. So for the bifurcation lesions, Anyreach 0.6C is very efficient. It's the usual workhorse wire, but if you have angulated bifurcations, or if you want to go through a stand, and if you have some tortuosity, then you can also use 0.3 P or C for crossing that obstacle and that lesion, using it like a workhorse wire. So the long diffuse lesions, and even in dissections, the 0.3 wire is an excellent wire to tackle that lesions. So it depends. If you have a very calcified and long lesion, then I prefer the P version, which is has a polymer jacketed sleeve, but the tip is still a floppy wire, and this is good to have better control and to engage the lesion. And for long lesions and for dissected lesions, if we have, then I would like to try the 0.3C type. If you have an ambiguity, or if you have a side branch coming up just in front of the CTO, then I would like to prefer 50% of my cases the Anyreach 6 gram H curve, the hash curve. But if it's a straight one without any side branch, then if you want to increase the support, if you want to increase the penetration force, then I would like to choose the straight one, so I can make a very small tip at the 1 millimeter beginning of the wire. Sometimes not just septal tracking, septal entrance is also a big problem. Sometimes you have a retroflex epicardial, or you have a retroflex septal, then the wire, the 0.3 P version especially, fault on itself, and with the knuckle you can sometimes very easily enter retroflex lesions, retroflex septals, and then you may not even to change that wire. If you pull the wire, it will straighten itself, and then you can use it again for crossing that epicardial collateral or septal collateral, whatever. The wire is resilient, it's resistant to damage, so you can use it in several times throughout the procedure.